start off with mechanisms, which I'm really interested to hear about the mechanisms and the genetic basis for interstitial lung disease. And it's a real pleasure that I can introduce to you Professor Raphaël Borie, who's a world expert on ILD and rare lung diseases and based in Paris in France. So Raphaël, welcome, and really looking forward to your presentation.
Thanks a lot for the introduction and thanks a lot for the invitation today. I'm ready to begin, if you are good with that. So we are going to talk today about the mechanism of ILD and particularly the genetic part of ILD. I have some conflict of interest to disclose related to antifibrotic drug. Why do we care about genetic in ILD? We care about genetic of ILD because there is an obvious increased case of familial pulmonary fibrosis. There is an ongoing ERS task force proposal to have a consensus definition of what is a familial pulmonary fibrosis, and we suggest that it should include at least 2 members. It should be at least 1 or 2 degrees of relationships, and it should not be limited to idiopathic ILD. And in this really recent American cohort of more than 1,000 ILD patients, we can see that in this cohort of 500 IPF patients, almost 1/4 of them reported familial occurrence of ILD. And in non-IPF patients, including secondary ILDs such as CTD-ILD or hypersensitivity pneumonitis, about 10% of them also reported a familial case of ILD. So this prevalence suggests that all ILD may have a genetic background. However, we need to go a little bit more closer on genetic. We know about genetic for years. From high school, we have learned about Mendelian disease. Mendelian disease are related to ultra-rare or rare variants, almost absent in the general population, but ultra-powerful and called the penetrance of the disease when a patient is carrier of one of these rare variants. At the other end of the genetic analysis, this is the genetic of populations, polymorphism, or called also SNP. And those SNP may be present in 10–20% of the general population. But when they are present, they increase the risk to develop a specific disease, such as idiopathic pulmonary fibrosis, but it's also true for well-known disease, such as diabetes, rheumatoid arthritis, and so on. They don't help us when we have to do a genetic counseling in familial pulmonary fibrosis, but they are super important when we need to think about what are the pathways involved in pulmonary fibrosis and what kind of treatment we should think about in those patients. The problem is that both genetics are present in interstitial lung disease. We are going to talk more about rare variants today, but the genetic of population is also true in interstitial lung disease, and particularly one gene called MUC5B. This gene is present in about 10% of the general population, general Caucasian population, but increase the risk by 6 for the carriers of the SNP at risk for IPF. But it indicates that it might be important from a pathophysiological point of view. But we are going to talk a little bit more about rare variants. If we go back to our first discussion about familial pulmonary fibrosis, we are able currently to evidence a mutation in one dedicated gene in about 30 to 40% of the familial case of pulmonary fibrosis. And you can see on this figure that there are a lot of genes already reported to be associated with pulmonary fibrosis. However, we can simplify a little bit this figure and merge the genes in 3 different groups. The first one and the most important one gathers a telomeres related gene. I'm going to go further on that. The second one is related to the surfactant pathway, mostly in children, but there are some cases in adults. And the second one is the different kind of syndrome, super rare syndrome, such as Hermansky-Pudlak and so on. So I'm not going to talk about it today. What are the telomere-related genes? The telomeres are located at the end of the chromosomes, and the telomere length decrease after each cell division, and then requires a telomerase activity to add DNA at the end of the chromosome and rebuild the telomeres. When one of these genes is mutated, such as TERT or NOP10, for instance, then the telomerase activity is decreased and the telomere length is also decreased after each division. The telomeres are located at the end of the chromosome and are stained in red on this figure. And telomere-related gene mutation may be associated not only with pulmonary fibrosis, but also with other kinds of diseases. They have been initially reported to be associated with hematological disease, such as aplastic anemia and myelodysplastic syndrome. They are also associated with liver cirrhosis. They were initially reported with a super rare skin disorder called dyskeratosis congenita. They are ultra rare in our patient, but our patient with familial pulmonary fibrosis may present a premature graying of the hair, such as this little dog on this figure. And obviously, they are associated with an increased risk of pulmonary fibrosis. Let's go back to our question. We've got a patient with familial pulmonary fibrosis. The first two telomere-related genes associated with pulmonary fibrosis were TERT and TERT, also called sometimes TER. And we are going to find a TERT or TERT mutation in 15 to 20% of these cases. And it's true whatever the cohort you are working on. The prevalence is increased currently because we have other genes to analyze. It's about 30% of the families. However, when you have a more precise phenotype, then the prevalence of telomere-related gene mutation increases. Indeed, if you have some extrapulmonary signs suggestive of a telomere-related gene mutation, whatever in your patient or in the family, then the prevalence of telomere-related gene mutation may be up to 100% when they are really well characterized. What are the extrapulmonary signs suggestive of telomere-related gene mutation? In the patient, they are often subtle. Indeed, about half of the patients with telomere-related gene mutation will present an hematological abnormality, usually really subtle, such as a low platelet count between 100 and 150 giga per liter, or an increased MCV just above 100. However, some patients may have a low platelet count or an increased MCV without TERT or TERT mutations. They may be associated with other telomere-related gene mutations, such as RTR1, or they may also be associated with other diseases that might be just coincidental, such as alcoholic consumption and so on. And about a little bit more than half of the patients won't present any hematological abnormalities. The third important point is the age of the patient. Obviously, when you've got a patient with familial pulmonary fibrosis, you've got to think about genetic analysis. But the younger your patient is, the higher the prevalence of telomere-related gene mutation will be. Indeed, in this cohort also of familial pulmonary fibrosis, and at that time we only analyzed TERT and TERT, between the age of 40 to 60, we evidence a more TERT and TERT mutation. Before the age of 40, most of the patients were associated with different kinds of genetic mutations, such as surfactant pathway. And after the age of 70, telomere-related gene mutations are rarer, and it's probably related to other kinds of genetic predisposition, might be related to MUC5A and so on, but they are not usually Mendelian. And it is super important for patients who are referred for lung transplantation, because those patients, as evidence in this recent American cohort, are younger, median age of 60 in this cohort of 150 patients. And you can see that already 13% of them were carrier of a pathogenic telomere-related gene mutation, without evidence for the familial history for most of them. And obviously less in patients who were not referred for lung transplantation. So the younger your patient is, the higher the prevalence will be of telomere-related gene mutation. Is the CT scan a clue for the genetic diagnosis? In other words, should we discuss genetic analysis in every patient according to the pattern of the CT scan we usually discuss in our multidisciplinary discussion? For most of the patients, no. Most of the patients will present with UIP, typical, probable, possible UIP, or undetermined for UIP for the new classification, between 80% of the patients. However, between 15 to 20% of telomere-related gene mutation, the pattern of the CT scan is not UIP, is inconsistent with UIP, or is suggestive of pleuroparenchymal fibroelastosis. And we need to work a little bit more on that pattern to know if we should discuss genetic analysis in all patients with pleuroparenchymal fibroelastosis. However, patients with telomere-related gene mutation may also have other pulmonary phenotypes. They may present hepatopulmonary syndrome with hypoxemia without or with little ILD, secondary to the liver disease. It might be really specific to the telomere-related gene mutation. They may present an increased risk of opportunistic infection for some kind of telomere-related gene mutation. It might be a problem for CMV after lung transplantation. And I don't know if CPFE, emphysema with fibrosis, is a specific pattern of a telomere-related gene mutation. I don't think so, but there are some data suggesting that it might be associated with an increased risk of emphysema. So the CT scan pattern usually doesn't help for the genetic analysis. And what about the pulmonary diagnosis? For most of the patients, it doesn't help either. In these two cohorts, one from France, one from America, from the Christine Garcia lab, about half of the patients had an IPF diagnosis at that time. And interestingly, 10% of the patients had a secondary ILD, CTD ILD, or hypersensitivity pneumonitis. What we can say from that is, whatever the diagnosis, the pulmonary diagnosis, the genetic analysis should be discussed, whatever an idiopathic or secondary ILD, if you evidence a familial case of pulmonary fibrosis. And what is important for those patients is that environmental are important. We discussed earlier about environmental risk factor. It's super important for telomere-related gene mutation. Indeed, interestingly, at least 60% of the patients with telomere-related gene mutation and pulmonary fibrosis, they report smoking or evident lung toxicity. It is also true for the liver disease associated with telomere-related gene mutation. In this French cohort of liver disease associated with TLS gene mutation, patients with alcoholic consumption of viral infection had a worse outcome and a worse transplant-free survival. And it's also true for the blood toxicity, as evidence after lung transplantation with a high risk of thrombocytopenia with cytotoxic drugs such as anciclovir for CMV or atatayoprim. So the environment is super important, as there are huge genetic and environmental interactions. Does this modify the treatment for the patient? We know now that anti-fibrotic drugs should be prescribed for IPF and for progressing fibrosis. And we know for sure that there are no specific side effects for telomere-related gene mutation carrier from several data. In this post-hoc analysis of the phase 3 study, the post-hoc analysis evidence a rare TRG variant in about 100 patients. And in red, the patient with rare TRG variant had an increased decline of FVC. But the patient in the dot line has a reduced decline of FVC compared to the patient in the placebo group. So in this phase 3 study, the pirfenidone was safe, and that was associated with a better outcome. And in this second study, an European multicentric retrospective study, 100 IPF patients who received either nintedanib or pirfenidone, no different side effect than those previously reported with antifibrotic drug. And the observed FVC was reduced compared to the predicted FVC with the pre-treatment data. So the antifibrotic drug are as safe as usual and are associated with a reduced decline of FVC. However, the patients are young, and as I said earlier, and obviously reported, should we discuss targeted therapy? Are we able to target the telomerase activity? And are some drugs targeting the telomerase and are associated with an increased telomere length, such as danazol, an androgen? And in this phase 2 study, a secondary outcome was lung fibrosis. And some patients report a stabilization of the lung fibrosis, but really low number of patients. That's why we are running a phase 2 study in France called Androtelo with danazol for lung fibrosis associated with telomere-related gene mutation. 25 patients have been included in the study, and the results are expected for this year. However, the patients are young and usually referred for lung transplantation. And I told you that they may present some hematological abnormalities, but we know for sure that despite the presence of a telomere-related gene mutation, the overall survival after lung transplantation is no different from the general population of ILD after lung transplantation, and is about 5 years in this really recent American cohort, and we've got almost the same data in France. However, some patients may present super severe hematological abnormality, and we suggest a precise phenotype before lung transplantation. And in this French cohort, patients with established myelodysplastic syndrome before lung transplantation had a worse outcome, and we suggest to really discuss and maybe contraindicated lung transplantation for patients with established myelodysplastic syndrome before lung transplantation, so it might be difficult to discuss. And now we need to talk about the genetic counseling for relative. I'm not going to talk too much about it because the laws are different according to countries. The genetic analysis availability are different from one country to another, but we need to be careful about it because relative may present abnormalities. They may present interstitial lung disease pretty frequently at the age of 50, in up to 70% of them. They may present subtle hematological abnormalities, and they also may present a premature egg graying for 40% of them before the age of 30. So they need at least a psychological support, and suggest to refer those relative to a genetic counseling. I will only have one slide for surfactant mutation, just to show that the pattern is most frequently not UIP. It might be ground glass opacity, cyst, reticulation. Patients may present with fibrosis, usually with upper lobes predominance, and it's usually not a typical UIP pattern. Some patients, particularly children, may be improved with steroids. I'm just going to say that there may be an increased risk to develop lung cancer. And for some families with ILD and lung cancer, I'd suggest to analyze SFTP1 and CTP2. And it will be my last slide. What are the current indications for the genetic analysis? This is the French proposal. This is going to be the ERS task force proposal. And we also did the physician and patient survey to offer a genetic analysis. And I know that genetic analysis is not available in a lot of countries, but I suppose that it's, and I expect that is going to be available pretty soon. So we suggest to do genetic analysis for familial pulmonary fibrosis, all familial cases, and we are going to evidence genetic mutation for about 40% of them. For short telomere syndrome, for patients with pulmonary fibrosis and liver or hematological syndrome, whether from the patient point of view or the familial point of view. And we also suggest to offer genetic analysis for patients with pulmonary fibrosis before the age of 50. And we can discuss genetic analysis before the age of 65 regarding the prevalence of telomere-related gene in this population. I thank you for your attention. I'll be pleased to discuss about it after the discussion of my colleagues.
Raphaël, thank you so much. That was a fantastic talk. It was very clear and really exciting to see this, these insights into the genetic contribution to fibrosis. So congratulations to you and to your colleagues, and thanks for taking the time to present it. We will come back to you with questions. Our next speaker is going to give a talk on the state of the art in pulmonary fibrosis. For a very transient moment, it looked like Katerina had changed. Our next speaker is Katerina Antoniou. She's going to give a state of the art on interstitial lung disease and concentrate on some practical aspects of the holistic care. And Katerina is chair of the ERS Assembly 12, which is the assembly that concentrates on interstitial lung disease. So as a working clinician and an active member of ERS, Katerina is really well placed to talk about this. So Katerina, thank you for joining us. I think you're all going to really enjoy this talk.
Thank you so much, Richard. Thank you so much, ERS. And I'm very honored to be here with you and to share with you some new knowledge about holistic approach in pulmonary fibrosis and some treatable traits.
All right, click on the PowerPoint.
Yes. Yes. So, as you know, pulmonary fibrosis is not only IPF, but we have a lot of other entities and diseases that could progress to pulmonary fibrosis, like connective tissue disorders and sarcoidosis and chronic HP. It was Professor Wells and European colleagues that some years before, with a Shakespearean title from Romeo and Juliet of What's in a Name, introduced the concept of progressive fibrotic phenotype. So actually reclassified interstitial lung diseases with diseases that beyond IPF progresses and have the same disease behavior like IPF. And maybe they share common pathogenetic pathways. So the concept of progressive fibrotic phenotype is very now trendy these years. For different reasons, because actually all these diseases with the prototypical of IPF show this lethal clinical progression and of course the poor prognosis. So the early identification of this disease phenotype is very important for the management, and antifibrotic treatments and therapies have proven efficacy in IPF. Genetics, as Raphaël told us, but also other biomarkers will allow us to determine the treatment response and to help to select a proper treatment of this individual for those individuals in the future, so to better endotype the disease. But what we know about epidemiology of these progressive fibrotic diseases? We don't know a lot, and actually a recent study that also Greece has been participated in 6 European countries, the PERSEIDS study from Omerus name, provided very recent data about incidence and prevalence, but also the rate of progression of these diseases. And most importantly, 1/3 of fibrotic diseases beyond IPF showed pulmonary fibrosis behavior with a UIP pattern, and most importantly, chronic HP was the most prevalent between them. What we know about the molecular pathways? As Raphaël told us, after an initial injury in a genetic susceptible individual, but also, of course, with the environment interaction, we have the assessment of ILD, the progression to ILD, and this is a sustained injury. However, with the progression of other factors would be the smoking or other factors would have the development of the ILD. With the expansion then of the fibroblast population, which is leading to fibrosis, unless the disease is stabilized through antifibrotic treatment or through the presence of some more antifibrotic mechanisms, while on the other hand, if we don't stop this, we will have the activation of these self-reinforcing loops activations and the progressive fibrosis. And most importantly, we will have different overlapping mechanisms to disease pathogenesis, and effective treatment depends on the accurate classification of disease endotype and phenotype to determine the optimal approach. And you see here that we have the antigen, the exposure, the inflammation and fibrosis, and main pillars of this process. And what is the concept of holistic approach in the management of pulmonary fibrosis? Of course, we have the antifibrotic treatment, and we have novel pharmacological strategies that Professor Kaminski is going to talk to you about that. But apart from that, we have to treat the treatable. We have to treat comorbidities, and we need to have non-pharmacological treatment and management of the acute exacerbations. And all of that would have a beneficial and support to our patients. And as you know, antifibrotic therapies do not improve symptoms or quality of life, and even if they slow down the disease progression as measured by forced vital capacity, they do not halt IPF progression. So we have the supportive therapies and the treatment of comorbidities. And moreover, we know that our patients are old enough, that we have the phenotype of aging population, and we have multi-morbidity, but also multi-pharmacy. We have a lot of concomitant medications that are burden our patients. And in this recent study by KRPF investigators showed that more than 40% of the patients experience adverse reactions leading to intolerance after the initiation of antifibrotic treatment. So in the center of here, on the circle, we have the comorbidities, and there are a lot of them. However, we don't have the time to discuss all of them. So I have chosen for you pulmonary hypertension, obstructive sleep apnea, and lung cancer, where I think that we will have recent developments and novel data are appearing. But we will start from the 70s, where the patient approach, the patient-centered care has been assessed in the literature. However, at that time, had an approach which was more doctor-centered. However, the concept of patient care is that each patient has to be understood as a unique human being. Only the recent years we have developed, by definition, only in 2017, the patient care approach definition, where encourages the active collaboration and shared decision-making between patients, families, and provides to design and manage and customize and comprehensive care planning. And we have 8 principles of patient-centeredness. And most recently, we have 2 position papers from different investigators, where they highlight the importance of patients' reported outcomes in order to participate and to link the drug therapy within the ILD management. And in this paper, they have identified 7 pillars that are important for patients, while in this paper, patients' participation in order to develop a tool like a PROM in order to measure the patient's activities is very, very important and should be included in the development of PROMs. And actually, this is the L pulmonary fibrosis questionnaire developed by Jeff Swigris, initially in IPF, but then also developed in pulmonary fibrotic diseases, such as connective tissue diseases and chronic HP, and is very important because it is assessing symptoms and quality of life. And moreover, it seems that it is beginning to have a clinical significant improvement after 1 year in symptoms and cough domain score after 1 year of intended treatment in this study. So in order to improve the quality of life in a study. One more concept that I would like to share with you is the frailty issue in pulmonary fibrosis and the need for a multidisciplinary approach. And we know that frailty is common in these aging and older adults with IPF, strongly associated with dyspnea and muscle mass, reduced muscle mass in our patients. And so we have to take in consideration their nutrition and their low physical performance in order to help them. Moreover, we have to involve the early detection of frailty and primary and secondary care services to prevent the overwhelming tertiary care demand. And one more issue developed by Sara Tomasetti in an Italian multi-center study is showing that we have to be trained in order to improve patient-centered medicine skill, and we have a lot of barriers in front of us that they hinder and hinder this communication, and we have difficulty in breaking bad news, deliver information about the lack of available curative therapies and the presence of caregivers. And in this article, we discussed the burden of IPF in emotional well-being and quality of life, highlighting that screening patients for impaired emotional well-being, anxiety, depression, mood disturbance, and poor quality of life should be offered routinely, and not only at baseline, but also in the follow-up of their trip. So this is the first cluster of diseases that we have investigated with Sofia Schiza, is the component of obstructive sleep apnea in pulmonary fibrosis. And the presence of obstructive sleep apnea has been associated, and more recently, it has been found from other investigators that male sex and obstructive sleep apnea are related with poor outcome in IPF. So management of OSA in IPF is very important, and due to the significant impact in life expectancy and quality of life. And this study, in the PhD thesis, we identified that in patients with IPF and OSA, which this percentage was more than 60% in our cohort, CPAP therapy has been initiated in this patient, and in patients that were compliant with more than 6 hours PAP use, at a 7-year follow-up, had a better survival. And not only survival, but better survival, but also they have improved the sleep scales, such as fatigue-related scales and sleep quality scales. And the second comorbidity is the pH, and this is the increased study where we know that it was the first positive study in this field. And patients with ILD or CT were group 3 pH documented by right heart cath, and the patients were under nintedanib or pirfenidone. However, it has been shown that in patients with FVC less than 70%, they were patients not only with IPF, but with different ILDs, inhaled treprostinil administered by ultrasonic pulse delivery nebulizer has been shown here that has been improved the primary outcome, which has been the 6-minute walking distance in week 16. And also importantly, in a post-hoc analysis of this study, they have been shown by Nathan and colleagues relevant changes in favor of this inhaled therapy in FVC in mLs, but also in predicted FVC in the whole population. Most importantly, patients with IPF, when they have been sub-analyzed, have gained more than 170 ml in comparison with control. And the third cluster of disease where we have to move in order to have a better approach to our patients is the IPF and lung cancer. And Algiris Zouvelekis, with the collaboration of 3 assemblies from ERS, 8, 11, and 12, our assembly, has developed a survey of 25 questions highlighting the importance that we need a consensus statement for the management of these patients. And the impact of acute exacerbation is well known in IPF. We know this is a lethal and with high mortality event in the disease course. And about the management, we have a huge confusion. We know that in this survey, international survey by Michael Kreuter and colleagues, it has been found that more than 90% of colleagues are using high dose of steroids and immunosuppressant therapy also, such as cyclophosphamide. And they use almost 20% the pulses of cyclophosphamide. And we have recently shown in the literature the French study, a phase 3 trial, which has been investigated the efficacy and safety of cyclophosphamide, of 4 pulses actually of cyclophosphamide in as add-on therapy to glucocorticosteroids in acute exacerbation of IPF. And the 3-month mortality, as you see here, has been decreased in patients that received cyclophosphamide. And as you can imagine, now we know that we don't have to use cyclophosphamide pulses in the therapy of acute exacerbation. Most importantly, a higher risk to death has been associated with severe IPF, so with low FVC. And importantly, the patients who were receiving antifibrotic therapy had 30% probability of less of mortality. And the importance of antifibrotic treatment, here nintedanib, has been investigated in the inbuilt study, where even in the whole population or in the UIP-like fibrotic study, it has been shown that acute exacerbation, time to acute exacerbation, is reduced by 40% in patients who were receiving the antifibrotic drug. We don't have to forget the non-pharmacological treatment, the oxygen, the lung transplantation, the mechanical ventilation with different novel approaches, such as ECMO and high flow nasal cameras and non-invasive mechanical ventilation, the pulmonary rehabilitation and palliative care, and of course, general measures like vaccination, quit smoking, and nutritional counseling. And our approach is starting from the bench, going to bedside into a patient-centered care using advanced research, precision medicine, and patient-centeredness. Of course, ERS is collaborating with ELF, European Lung Foundation, and ensures policies that are based on science and patient needs and patients' participations, not only in activities, but also in guidelines and research statements. And of course, clean air, as we have discussed in the climate change session, benefits from physical activity and smoking cessations are very, very important. And I would like to stop this presentation sharing with you the Hippocratean knowledge, actually, that it's far more important to know what person the disease has than what disease the person has, which actually summarizes what we have discussed with you today. Ευχαριστώ πολύ. Thank you so much.
Katerina, many thanks, and thanks right at the very end for reminding us the fathers of modern medicine coming from Greece. It's a fantastic talk, and I'm sure we'll have lots of questions around that coming up from the panel and also from the wider audience a little bit later. So we're going to move now from Greece across to the US, to Yale University, and I'm going to invite Naftali Kaminski to now join us. And Naftali is going to speak to us about the current and emerging treatments in ILD. So Naftali, over to you.
So I want to thank the organizers for inviting me to give this talk. It's a really exciting and amazing forum. Looking on a map of Europe, I cannot help but reflect between the dramatic contrast between what we're doing, trying to improve health and safety of humans, and what's actually happened in reality. So let's not remember this today. Let's not forget this today. I am a consultant to multiple companies, and I'm want to share this very quickly. And this was mentioned before. When speaking about fibrosis and pulmonary fibrosis and treatment, you want to remember exactly that we're not dealing only with IPF, and we're dealing with the recently introduced concept of progressive fibrosing ILDs, which include autoimmune exposure, genetically mediated inflammatory disease, and also idiopathic pulmonary fibrosis. Of course, and this is the conceptual treatment framework. This was introduced by Kerry Johnson and Lancet. The idea is that you have drugs that are antifibrotic, drugs that are anti-inflammatory. The drugs that are antifibrotic can also be in non-IPF, can also be used in non-IPF ILDs, whereas at least the current antifibrotics anti-inflammatory should not be. And today I'll speak mostly about antifibrotic therapy and really focus about IPF. So antifibrotics. Just a reminder to all of you, idiopathic pulmonary fibrosis, progressive form of fibrotic lung disease, exclusion known of causes of the disease, probably 200,000 in the US, 6 million worldwide, defined by this pathological UIP pattern, both of biopsy and AHRCT. And really, this is the center of everything, the myofibroblast foci, the peripheral involvement. And what you want to remember, and it's very simple, is the incidence increases with age. Certain ages more commonly in cancer, extremely rare below 55. Median survival is 3 years, but it actually can range from 1 to 12 years. 30,000 deaths in the US. The only curative treatment is lung transplantation, and it has, as you heard before, a strong genetic component. And as I'll tell you in a second, immunosuppression kills our patients, but some drugs can help them. This is another thing you want to think about, it, which is that IPF science has really exploded in recent years. This is basically a figure of all the numbers in PubMed, the National Library of Medicine resource for scientific papers, and normalized to 2002. And basically the dashed line is all the papers. And the colored lines are different disease states. So for instance, cancer drives PubMed, so it's really all net. But diabetes mellitus, yellow, is here. And if you look at it, many other diseases like coronary heart disease are actually below PubMed. But this is the field of IPF, this red line. Look at this, a dramatic exponential increase in the number of papers and also in the quality of papers, the best journals and highly cited papers. This is dramatic explosion. We actually bypassed PubMed by over tenfold. Of course, if there's young people watching this presentation, you may want to say IPF has done its share. Maybe there's another lung disease I can study. I will recommend studying sarcoid, really behind PubMed and deserves its progression. Why this has happened? Probably the discovery of genetics of IPF, which again was mentioned, and the two FDA-approved drugs. It really generated interest, increased funding, and really caused this explosion of information. I will also mention something that I hope, which is more of my contribution, the detailed description of all the cells in the IPF lung, which has happened in the last 2 years. As you all know, and you've seen this slide probably a million times, there's been a dramatic increase also in the clinical trials. When I finished my fellowship in 2000, people said that you could not do a randomized controlled trial in IPF. And look at this increase. I will not go over all of them. This will take us a whole day, but I will summarize something. And this is, we have actually good news. We have the two FDA-approved drugs. We also have a lot of helpful negatives. Immunosuppressives are detrimental, antibiotics don't work. We have the difficult, we have 11 compounds that stopped because of safety or lack of effect. We have one interesting new sort of out of left field study, drug, inhaled treprostinil, and we have the hopeful, many more trials are coming. So what are the helpful negatives? I want to reiterate this, although everybody's aware, the most important thing is, again, when I finished my fellowship, this was the idiopathic pulmonary fibrosis diagnosis and treatment international consensus statement, recommendation of treatment with corticosteroids, azathioprine, or cyclophosphamide. These are extremely established people. They were not wrong. This was the data they had. Luckily, and also based on some work that showed that actually there was no evidence of real inflammation in the IPF lung. The Panther group that did the classical study of comparing prednisone, azathioprine, and acetylcysteine for pulmonary fibrosis. And basically, this group of investigators showed that there were increased risk of death, hospitalization in patients with IPF who were treated with a combination of prednisone, azathioprine, and NAC as compared with placebo. NAC offered no significant benefit with respect to preservation of FVC in patients with IPF. And I think this was the beginning of the end of these drugs in idiopathic pulmonary fibrosis. It is still used in other ILDs, and again, with very little effect on lung health. It is still used in acute exacerbations of IPF without any evidence of benefit. And hopefully in the next few years, we will see more information. I did mention antibiotics. So there were really amazing work in the last couple of years from Phil Molyneux and from David O'Dyer and in groups in the US and Europe, in the UK, that basically showed that the microbiome is altered in patients with IPF. This led to 2 large clinical trials which studied cotrimoxazole and other antibiotics in IPF. And basically, these studies had the same results. They showed no effect on IPF on treatment with fibrosis, on treatment with antibiotics. Of course, our biggest success is the antifibrotics themselves. Nintedanib, a repurposed drug that was developed for cancer, triple kinase inhibitor, inhibits VEGF, PDGF, FGF, activates phosphatases, has multiple effects. I remember the excitement when we started seeing these results and when this paper came out on the efficacy and safety of nintedanib with Luca Ricaldi as the first author. And basically, again, everybody's familiar with these results, but I'll show the magnitude, because what's impressive is when you think about the fact that this is a study published 7 years ago and has been replicated multiple times. This antifibrotics really work. And basically what we see is this 40% reduction in the decline of forced vital capacity. The other drug that came out the same year is pirfenidone, an antifibrotic. Molecular target is not clearly known. Active in multiple animal models of fibrosis. As somebody who did the experiments, it's actually not that powerful, but it is an inhibitor of Wnt pathway and TGF-beta and other things. And impressively, it worked. The same exact effect, or almost exact effect, on pulmonary functions in patients with IPF, the reduction in the decline. So pirfenidone also slows down FVC decline. Since then, we've seen multiple studies, and this is the 8 years later, you could say hashtag antifibrotic works. Almost every study has shown that antifibrotic treatment, they don't make the patients feel better, but they improve clinical outcomes in patients with idiopathic pulmonary fibrosis, improve the decline, and have implications on survival. And this is just a systematic review and meta-analysis that showed that actually there is both a beneficial effect on mortality and also reduction of acute exacerbations, which are a driver of mortality in patients with IPF. So 8 years later, if we summarize antifibrotics, nintedanib and pirfenidone, one is they have substantial side effects. The patients really know they're taking the drug and they really are unhappy. But these side effects are actually not dangerous. They slow down disease progression as measured by FVC. They do reduce mortality. They reduce acute exacerbations. And what we learned also, that patient initial presentation doesn't really matter. There is a tendency sometimes to hold off of therapy because the patient is early in the disease or late in the disease. All evidence suggests that you should just treat the patient if you made a diagnosis of IPF. There's no difference progressive versus stable. There's no difference young versus old, and it's not only IPF. This is a classical study published by Kevin Flaherty and the INBUILD trial, which showed that nintedanib is effective in progressive fibrotic ILD. It's all been studies in scleroderma. So definitely these drugs will help. With regard to pirfenidone, a double-blind randomized placebo-controlled study didn't meet its primary endpoint, but did show on secondary endpoints that suggested that this should be continuously studied. The intriguing, and that's sort of what I call out of left field, or the things we did not expect to see. One is recently reported treprostinil, a synthetic analog of PGI2, and this was mentioned in the previous talk, inhaled treprostinil and pulmonary hypertension due to interstitial lung disease has a beneficial effect on exercise capacity. And since many of the patients with IPF, the investigators actually looked forward, and what they saw is that basically patient treated with inhaled treprostinil actually had evidence of slowing down or maybe even improvement in forced vital capacity. Of course, it's hard to know in such small numbers and in the retrospective analysis if this is really an effect, or maybe just this is regression to the mean. However, this is exciting. And a prospective randomized control study designed to evaluate the safety and efficacy of inhaled treprostinil in subjects with idiopathic pulmonary fibrosis over 52 weeks has been started. So this is really exciting and a little bit unexpected. What's next? My teams and others have used the novel new technologies that allow us to basically profile every single lung in every single cell in the IPF lung. So we can test all the genes in every single cell. This is exciting because to treat something, you need to know what's wrong with the organ or what's wrong with the patient. 2 years ago, we published 2 papers back-to-back, my group with Ivan Rosas as a collaborator and John Kropsky and Nick Banovich, which described over 500,000 cells from 42 IPF patients, 32 controls, others, characterize all the cell types in the IPF lung. This is actually how the data looks. If you raise your phone and scan this QR code, you have access to the data access. And basically what we did is we discovered novel cell type, the aberrant basaloid cell types, cells in IPF, collagen 15 endothelial cells, and profibrotic macrophages. And the concept that what happens in IPF is proximalization of the distal lung, replacement of alveolar epithelial and endothelial cells with airway cells. Relatively simple. So what happens in IPF, this is sort of the normal lung structure, very simplified, and you have type 1 alveolar epithelial cell injury. You have alveolar type 2 cells proliferating, trying to replace them. If you have aging telomere mutations, you generate ER stress, short telomeres, dump amended DNA. This causes actually activation of fibroblasts, a stiffer extracellular matrix, recruitment of monocyte-derived macrophages from the peripheral blood, myofibroblast transformation, migration or appearance of aberrant basaloid cells. But the main thing is the loss of the respiratory unit. This beautiful unit built for gas exchange is now something that's populated with cells built for gas delivery. Definitely you can't really breathe with it. The cool thing is that now we can know where we need to intervene, and there's multiple steps. So of course, I won't go into every detail, but I'll just mention 2 things. One is the profibrotic macrophages highlighted initially by Sasha Misharing. These are all the inflammatory cells in the lung. Every dot here is a cell, and that's their gene expression. And here, this is colored by disease. So red is IPF, yellow is COPD, and blue is control. And you can see there is this bleb here, which are macrophages. And they have distinct markers, including osteopontin and YKL-40 and MMP9. And basically, they have this signature, which is really associated with fibrosis. And frankly, if you have a drug that wipes this signature, you probably have a drug that treats fibrosis. Enter a molecule that was studied long ago, pentraxin-2. It is a modulator of macrophage activation. And in phase 2, it actually showed less decline in FVC, less decline in 6-minute walk, and it was well tolerated. So again, there is now a phase 3 ongoing, and hopefully we'll see results. Another side of it is the discovery of aberrant basaloid cells. These are the epithelial cells at the edge of the myofibroblast foci. They have unique markers. And one of the things that they express, these are these cells that were used to call regenerating pneumocytes. They express alpha V beta 6, an integrin that activates TGF-beta. And I actually started my career studying this integrin more than 20 years ago. And several companies have developed integrin inhibitors and actually have shown that inhibition of the integrin may reverse fibrosis and precision cut lung slices from human patients with IPF. And basically a phase 2 is happening as we speak. The last thing I want to mention is a little bit repositioning. Greg Downey and Leslie Cousins and others have looked for an IPF signature of something that would be better than nintedanib, basically looking at a lot of gene expression data, and what came up was sarcatinib, a small tyrosine kinase inhibitor that is inhibits SARC and developed for cancer and Alzheimer, tested in humans, very safe, but didn't do anything. And in collaboration with my group, me and Greg Downey and Farid Angari showed in animal models of disease and preclinical models that sarcatinib reverses fibrosis in the animals. We formed a small consortium with Danielle Antinozarkis and Maria Padilla and Mouse Sinai. And 3 years after the initial observation, we started a phase 2B. The only thing is that this phase 2B started a month before the pandemic, so we've had a hard time recruiting in the last 2 years. But this is an example how by integrating genomics and drug repurposing, you can go not 20 years from discovery, but within 3 years from discovery to a trial. So just to summarize, the take-home points are, one is treat your patients with antifibrotics. There's no reason to be nihilistic about it. They're highly effective for disease progression, mortality, acute exacerbation. Remember what is dangerous to our patients. Suppressing inflammation. Remember what does not work. If your fibrotic patient has a condition that requires antibiotics or PPI or something else, give them. Otherwise, do not. Offer participation in clinical trials. We have promising drugs. We know how to run the trials, and negative trials help. And our understanding of pulmonary fibrosis is really unprecedented. And our biggest threat is actually the pandemic, because beyond the threats that it caused to our patients, it's also slowed down communications and definitely slowed down patient recruitment. Many studies are at risk for stopping because of futility. This could be a dramatic slowdown in the road to cure IPF, and all of the community should unite to make sure that this doesn't happen. Thank you, and I'll be available for questions afterwards.
Naftali, thank you so much. That was an absolutely fantastic talk. A really clear, lovely translational medicine. It's much appreciated. As you say, we're coming back to you for questions. I'm going to bring in our next speaker, who is at the Brigham and Women's Harvard Medical School, Rachel Putman. Rachel, thanks very much for joining us. Rachel, you're going to do the task of looking at the horizon and addressing what's coming down. You very helpfully put some questions that are specifically on my mind that you're going to talk about. So I'm delighted that you're going to do this, because you're obviously looking at this from the point of view of a clinician as much as a scientist. So Rachel, thank you for joining us. We're really looking forward to your talk.
Thank you so much for having me. I really appreciate the invitation and being able to speak here. It's a really new and interesting format, and hopefully we can all think through these ideas together, because I think as POs, we definitely have, I would say, more questions and answers in my session. So I'm going to talk a bit about, can we identify people who are at risk for developing ILD later in life? So just briefly, we're going to start with going through early interstitial lung disease and talking about the epidemiology, the risk factors, and just touch a little bit on the genetics. And this is going to be to try and put together a profile where we can potentially evaluate or create a higher risk population. We're going to move a little bit into screening and evaluate the evidence that exists. And again, sort of think about how we can formulate a population that we should be screening, if we should be screening at all. And then talk about how we should follow these patients, what the current recommendations are, talk a little bit about the data that exists and the data that I wish existed, and the role of quantitative imaging. So first, to go through sort of the epidemiology and risk factors of early interstitial lung disease, we know that it's actually fairly common, so much more common than was previously thought, has been shown over the last 10 to 12 years. And in older individuals, most studies are looking at people over the age of 50 to 55. And these cohort studies, the prevalence ranges between 2 and 9%. We know that it's associated with an increased smoking history, increase in respiratory symptoms, that patients who have, or research participants who have these early changes have decreased exercise capacity, and they're also less likely to participate in exercise. We know that they have decreased lung volumes, a decreased diffusion capacity for carbon monoxide. There's multiple environmental exposures that are associated with this. And that these patients who have early interstitial changes are at an increased risk of death, and that's been shown sort of repeatedly. So although these changes are considered early, still definitely clinically important. So just to briefly touch on the genetics, I know we had a much more thorough talk earlier that was outstanding. When we look commonly sort of in these groups, the most replicated finding has been, and these are in predominantly in the US non-Hispanic white populations, and then populations from Europe, is the association between the MUC5B promoter polymorphism, which is also the most commonly associated genetic mutation in IPF. And so this is just a large GWAS that combined 6 different cohorts of early interstitial lung disease, and again showed this highly significant association with MUC5B. There's also been increased look at telomere length, and what we've seen is that patients with early ILD do have a decreased telomere length. So there are 2 cohorts in the US that have shown this, and for unaffected first-degree relatives of family members with pulmonary fibrosis, so not just IPF, any fibrotic lung, interstitial lung disease. And then more recently, 3 research cohorts have been shown that interstitial lung abnormalities, or a CT marker of early ILD, are associated with decreased telomere length. So when we're thinking about sort of how we can narrow a cohort to predict what you might find on CT scan based on those things, just to walk everyone through this figure, what we have in panels A, B, and C are 3 ROC curves, or sort of how well the prediction is for these markers. Here in panel A, we have just clinical covariates. So looking at people's age, sex, smoking history, we can sort of see how well, taking those things together, we're able to predict whether they would have early interstitial changes on CT scan. And the area under the curve is 0.67, so about 70%. So a little better than just sort of flipping a coin, but not great. Here in panel B, what we see is you're adding, the clinical characteristics are still here in yellow. And then what you're adding in green are physiologic decrements. So meaning if patients have these clinical characteristics, and then we add pulmonary function testing, which is predominantly in these cases reduced forced vital capacity or diffusion capacity for carbon monoxide, you can see that our ability to predict whether someone will have interstitial changes on CT scan goes up, from 0.67 to 0.77, so about a 10% increase in the likelihood of finding these changes on CT. And then finally, if we add, again, the yellow line here in panel C is again just the clinical covariates. Here is physiologic decrement, so the pulmonary function test abnormalities. And then if we add reduced telomere length and MUC5B genotype, what you're going to see is that we go to a little over 80% in our ability to predict interstitial changes on CT scan. I'm not suggesting sort of just focusing on telomere length and MUC5B, that these the patients with early ILD don't have other genetic mutations. However, when we're thinking about looking at large cohorts of people and thinking about how we would move towards screening, rare variants make that much more complicated. So unless we are going to move to a sort of more widely spread full exome sequencing or large panels of genetic testing, when we're thinking about sort of what's most common, this is what's been shown in the past and repeated across other groups. So now I think it's important to take a moment and think about, should we be screening? And I think this is an important question because people are very interested, including myself, in this question. And it's where sort of my research life and my clinical life sort of come together. And so I think to take a step backwards, it's important to go back to what's the principle of screening? So when we think about the principles of screening, it's the application of tests to a population with no overt signs or symptoms of disease. And the goal is to detect the disease at an earlier stage so that treatment will be more effective. And so I think keeping this in mind is how I've been trying to think about this question going forward, and trying to separate a little bit my research interests from what's sort of best as a population at whole. So I think the first question is, can we really identify this higher risk population based on known clinical risk factors? And can we potentially leverage electronic medical records to select these patients for evaluation? There's actually a study that is making its way through to publication, looking at 2 different hospital systems where using the electronic medical record, people were able to come up in artificial intelligence and machine learning, come up with an algorithm to select patients that were actually at high risk of having these changes found on subsequent CT scans. There's, again, using just baseline characteristics like we reviewed, you can get around 60%-ish or a little better. Then adding any sort of pulmonary function testing obviously increases the likelihood of selecting these patients. And now other health systems, they work very differently than they do here in the US. But these tests are ordered by sort of all different subspecialties and people are looking for different things. And so sometimes I think there's a lot of information in the medical record that we just miss based on what is sort of who is reviewing the information and this sort of the reason they ordered it and their background in subspecialty. So I think there is more information about these patients out there that we can probably leverage to follow and screen these patients moving forward. Again, I think we need to think about what role should genetics play. And as we're talking about this, I know in Bruno's talking about sort of moving forward with genetic screening and genetic testing in patients with family histories and how we sort of move this into a wider role. And then I think the background, at least particularly here in the US, where we have an insurance-based system and patients have to pay for these things, sort of what equity or inequity are we introducing into the system when we think about sort of adding genetic testing to a screening role? And then do we have evidence that actually detecting ILD at an earlier stage leads to more effective treatment or even as effective treatment as patients who have IPF? And just to go back briefly, sorry, to the prior slide, thinking about Dr. Kaminski's last talk, when we talk about sort of the sentinel trials in IPF and looking at antifibrotics, looking at the trial that came out for pirfenidone, the initial trial, the mean FVC in those groups was around 69%. So predominantly maybe not an earlier stage group of patients. However, in the nintedanib trial, the mean FVC was around 80%. Less so an in-build, it was again around in the high 60s and 68 or 69% predicted in terms of FVC, suggesting that maybe based on the IPF data from nintedanib, there could be patients with less severe disease could benefit. And there have been subgroup analyses that have showed this, but I don't know that we sort of have the broad data across all types of progressive pulmonary fibrotic diseases to know whether patients with early disease will benefit or if the degree of benefit is as much. And so when we think about screening, do we really have the ability to offer these patients treatment or prove that we're going to have benefit for them? So in the last couple of years, the Fleischner Society got together to sort of try and come up with a true definition of interstitial lung abnormalities and try and see if we can try and get the community to use common language. And I think that's because this has been an area of research that has sort of grown exponentially over the last several years, but it's also still very early. And with multiple different groups using different terms, it's helpful if we can sort of get all on the same page. This is their proposed algorithm for the evaluation of early interstitial lung disease. And as a radiology group, this is all based on sort of finding these changes on a CT scan. So here they're talking about the top of this algorithm starts with you find interstitial abnormalities. So early changes on a CT scan in someone who you necessarily didn't expect to find them that are predominantly subpleural reticular, can have more advanced stages of fibrosis, can have some ground glass and central alveolar nodularity, but it shouldn't be just those things. It should be have a combination at least, because we know that patients with just central alveolar nodularity behave very differently. And then if you find these things, the next step is to consider a high-res CT scan. And that's basically just based on, is there sort of how good is the first set of imaging? Do you feel confident in your ability to call what you've seen based on what's available there? If not, so if you aren't, or there's a partial CT scan, or potentially someone had an abdominal CT scan where only part of the lungs were imaged, it's reasonable to move forward and get a high resolution CT scan to better understand what's wrong with the patients. So now you have an abnormal CT scan and you need to go to the patient and understand what's happening with them, as we all do when we see patients in clinic. So do they have respiratory symptoms that could be attributable to ILD? How extensive is the disease on CT scan? This is where these things can become definitely a little bit different from person to person and more qualitative and quantitative. And then are there decrements in pulmonary function that go with this that are attributable to the changes on CT scan related to changes in gas exchange and lung volumes? Because as has been shown repeatedly in the research, most of these patients actually experience decrements in gas exchange, meaning decrease in DLCO before they will show changes in lung volumes. So the DLCO generally is decreasing before the forced vital capacity in these patients. If they have any of those things, so abnormal pulmonary function testing plus an abnormal CT scan symptoms, they likely have clinically significant ILD and should be seen by a pulmonologist, ideally someone with experience in ILD, if possible, with access to multidisciplinary discussion, but recognizing that that's not necessarily available everywhere. If they don't have any of those things, they just have the CT findings, then they would fall back into interstitial this sort of category of interstitial lung abnormalities again. And from here, based on prior data that has come out from different groups, they recommend using the features that you see in radiology and then some of the high-risk clinical features to look at the risk of progression. So evidence of more architectural distortion, traction bronchiectasis, a predominantly subpleural pattern. Is it an early UIP pattern or probable UIP pattern? If yes, they recommend risk factor reduction, which is predominantly smoking cessation, and obviously removal of any clear environmental triggers if you're able to find them. And then reassess clinically with repeat pulmonary function testing and an exam in a timeline of 3 to 12 months. And I think that's very much going to depend on the patient, how symptomatic they are, and what you're finding in their pulmonary function testing. And then repeat imaging sometime in the next 1 to 2 years. The question becomes, how long are we following these patients if they're remaining stable, and how often are we imaging them and getting pulmonary function testing, all of those questions. If they don't have any evidence that higher risk factors for progression, meaning maybe their scan looks more inflammatory or it's very, very mild, they're non-smokers, they don't sort of have any other high risk of progression, then you recommend risk factor reduction again if there are any. And then this is the sort of reassess if their symptoms develop, although we also all often know that sometimes by the time these patients develop symptoms, they can have much more advanced changes on CT scan. So while I think this is a good blueprint, and some of it is definitely driven by research cohort data, it still leaves a lot of questions for us that are unanswered clinically when we see these patients. So I want to just briefly touch on the role of quantitative imaging. So there are multiple methods out there. These first three look at sort of just the attenuation on CT scan, meaning how much is dense, looking like water versus looking like air. And the idea being that more fibrosis looks denser on imaging. And then there are multiple other tools that use sort of objective identification of features. So high attenuation areas have been shown by a couple of groups to be associated with interstitial changes, although it's been sort of cohort to cohort. There's not complete agreement that this is truly specific for early interstitial changes. And then other groups have used techniques similar to this, where people will go through and label different features on CT scan and add up the amounts of them for a more quantitative approach. And would it be possible to use these to look for progression over time as opposed to using pulmonary function testing, or at least have a more objective way to measure radiographic progression over time? And again, the idea being that maybe there's less bias, higher throughput, and can we combine these with clinical features to help understand how patients are progressing? So as we talked about, we can use current risk factors to identify those who are high risk. We can probably improve the prediction with some addition of genetics, but we do need a lot more studies to understand the benefits of treatment and how often we're supposed to be following these patients and how to best monitor them over time. And again, I want to thank you all for inviting me to give this talk, and I'm looking forward to the discussion.
Rachel, many thanks for that. That was really excellent, and it really gave us the clarity around the challenges between early screening and what are you actually looking for, and then what does that mean in terms of what interventions do you do, or the frequency of follow-up and following up with what. And my thanks also go to the other speakers, Raphaël, Katerina and Naftali. So I'm going to go to the panel of experts to have the first opportunity to ask questions of our speakers. So let's start with Petros.
Hello. And first of all, I would like to thank all four speakers. I would like to thank all four speakers for their excellent talks. My question is to Professor Kaminski. From the new treatments, future treatments that you presented, which one do you believe is the most promising, and whether there is space for combining treatments in patients with IPF?
So it's hard to say which one is most promising. Actually, I once offered that we should have a website in which we all put our bets on what is most promising and then see if we predicted correctly, right? Because when a study succeeds, we all said we knew it, and when a study failed, we definitely say we knew it. So it's hard to predict. I do think we need, based on our data, targeting only fibrosis is going to slow down disease, but is not going to improve the patients. So while antifibrotic to target the fibroblasts, myofibroblast foci are important, we have to have strategies that improve the epithelial cell function and macrophage function. And that, it's in some ways is an answer to your second question, which is actually today I'm giving a talk at NHLBI, which is called Who Did It? Like, what is the cell that's responsible for IPF? And the answer is that there's not one cell that causes IPF. And that suggests that at least in patients with progressive disease, not in early ILD, we will need combination therapies. And we need to start doing studies in which we take a risk and give induction of remission therapies and maintenance, basically follow the cancer model. Single therapies, low dose, low risk therapies will probably not lead to a cure. So hopefully this answers your question.
Thank you.
Naftali, thank you. Joanna, what's your thoughts and question?
Well, first of all, let me congratulate. That was a truly outstanding panel, very inspiring. I learned a lot, and I have a question, I think, to all of you, because all of you addressed the molecular mechanisms of ILDs, the genetic risk factors, as well as the potential screening. So as we know, the lung fibrosis is an independent risk factor for lung cancer. So what do we know about the mechanisms leading to the tumorigenesis in lung fibrosis? And are there any biomarkers in the pipeline that could potentially help in identifying ILD patients with the higher risk of lung cancer? Thank you.
Joanna, I'll try and unpack that because there's a lot in there. So I think there's a question around genetics and how that then links into then downstream mechanisms, how that links to biomarkers, and how that links to treatments. So I think there's a lot there. So perhaps if we actually go in the order of the speakers. So Raphaël, if you want to try and tackle that from the sort of genetic perspective around how the genetics then link into then the disease manifestation, perhaps through functional genomics.
So I'm going to talk about really a few patients. So don't make an argument for the whole patient with IPF and lung cancer, but we know for patients with telomere-related gene mutation that prevalence of lung cancer seems somehow rare compared to the whole population of IPF. But to the other hand, the patient with surfactant pathway mutation may have an increased risk to develop lung cancer. So it might be related to the long duration of pulmonary fibrosis. So it might be the treatment of IPF that might reduce the risk to develop the lung cancer. So that would be my point, suggesting that the more powerful you have a treatment to IPF, the less risk you would have to develop lung cancer.
Katerina, your thoughts on the question linking between the genetics mechanisms and how it also then links into our understanding of lung cancer as well?
Yes, actually, we know that IPF is linked to lung cancer, and IPF patients have an increased risk of developing lung cancer. So it is important for ILD clinicians, as they follow the patient with IPF, also to take a close follow-up their CTs, and we do that in order to have the development, to see if we have the development of lung cancer in the top of pulmonary fibrosis. And this condition is difficult to manage condition. There is no consensus, as the survey from ERS has been shown, and we need a consensus statement. Regarding pathogenesis, there are a lot of common pathogenetic pathways that they link those conditions. And the screening, also with artificial intelligence, has shown that starting to identify ILAs, Joe Jacobs has shown that 11% of these patients have been found with lung cancer. So it is very, very important.
Katerina, thanks. Naftali, if I sort of broaden the question, Joanna, if I may, to then think perhaps beyond just lung cancer, but also around the fact that some of the treatments clearly have a very well-known underlying mechanism of action, but in some it's less certain. And indeed, the genetic understanding at the moment probably hasn't been fully translated into therapies. So are there particular, whether it's the common variants or some of the rarer variants that Raphaël was talking about, that you think are really now ripe for new treatment interventions?
I'm not sure. I think there is a difficulty. I do think that targeting some of the rare mutations, and in some ways, following up on the beautiful example we saw in cystic fibrosis, when you start by developing a therapy that targets a really rare mutation and then sort of extending it to the population is really good. So maybe drugs that target ER stress, for instance, as a model going for initially rare patients with surfactant mutations and then sort of extending it to the population. Our community hasn't done this. Some of the other mutations we find, especially the MAC5B, are, I would say, probably 3 or 4 degrees separation from the direct mechanism of the patient. I do want to highlight 2 things going back to the lung cancer question just quickly. One is Lung cancer is actually overlooked in IPF patients, and I think we have to pay attention to it. I have an IPF registry, used to have it in Pittsburgh, and the longest living patient who lived 12 years with stable IPF died of lung cancer, which actually was not seen in his CT during screen. So we do need better biomarkers and better ways to look at our patients, and AI is critically important there. The other thing is, when you look at the cell populations in the IPF lung, the epithelial cells are a little bit, should I say, crazy. And there's a lot of basal cells that are out of context. And you could envision when cells from a patient who smoked now are also in a very high reactive oxygen into ROS environment and stiff matrix, probably they cannot become malignant. So we do need to study these in more detail and actually collect tissues of patients who have both IPF and lung cancer.
Thank you. Then Rachel, just give you a chance to have a brief comment on this as well. But what I'm perhaps specifically trying to think about as well is, if you're thinking about screening and then linking it in with lung cancer and ILD, is the prospect of CT screening for lung cancer an opportunity for screening for ILD at the same time? Is that a new opportunity?
I think it's an underutilized opportunity at the moment, based on the data that's out there and the work that's been done looking at the Pittsburgh sort of lung cancer screening cohorts. I think it goes both ways. I think hopefully pulmonologists are paying attention to nodules in their IPF patients as we're scanning them, but also patients that are getting lung cancer screening CTs, given that the underlying clinical risk factors are so similar, often have early interstitial changes that are not detected, or they're not just not acted upon because it's not the reason the CT scan was done. So whether this isn't a chance for sort of AI based on automated detection in the CT scan itself, in the reports to flag providers, or to sort of flag the medical record, the person ordering the CT scan, all of those things are possible and could be very useful going forward, helping to detect these patients and hopefully not miss people in either direction and get them into the care that they need.
Rachel, thank you. And Joanna, thank you for such a great question that triggered such a discussion. So Borja, do you want to come in next? But if you could just target one question to one individual, because I'm sure that Richard's got a number of questions coming in from the audience. So Borja, over to you.
Yeah, thank you, Chris. My question is to Dr. Kaminski as well. Well, first of all, thank you, everyone. I mean, terrific talks. I learned a lot. Dr. Kaminski, my question is regarding the new treatments. You made a very comprehensive view of the current and future treatments for ILD to stop the progression of the disease. But one thing that clinicians are worried about is exacerbations of ILD. Is there any new treatments coming for treating exacerbations? Because we're still treating them with steroids or immunosuppressants, and probably this is not related to inflammation at that point. What is your view about that? Can we tell us about something about new treatments for exacerbations?
So if you look at the acute exacerbation, one is, I do want to highlight, I am excited by the analysis that suggests that antifibrotic reduced the rate of acute exacerbations. Again, so it's almost like when I travel in the world, sometimes I tell patients, I tell physicians, stick to the ground rules, right? We have good drugs, right? And we have to give it to everybody that's eligible, right? If there's indication. The problem with acute exacerbation has been the notion in the community that you cannot run a randomized controlled trial. And I think this is changing now. There have been studies from Japan and from other places that suggested that you could do it. Most of the focus has been on anti-inflammatory. There's been studies on polymyxin and plasmapheresis, and I don't know that anything is really effective. By the time the patient shows up, there's no evidence for real active inflammation. So in some ways, giving steroid this is I don't know if we're helping or not, probably the horses are out of the barn. Maybe it's a little bit like other diseases that maybe if we could give the patient the anti-inflammatory drugs even a week or two before the acute exacerbation would have been better, but we don't have biomarkers. So I think we need basically randomized prospective studies and looking at strategies that may improve the survival of the epithelium at the late stage. But we don't have anything promising right now. The only positive I can do is we have a good definition and we have shown that these trials can be done. And maybe a European initiative for something like REMAP-CAP or like the pragmatic trial designs in which a big network that every patient with an acute exacerbation is enrolled into a study will help us, and we just need to start shooting, increase shots of goals.
Great questions from the panel, and that really is a study to design for the future. Richard, I'm sure there's been a lot of interest coming in from the audience.
Yeah, there has. Chris, there has. Thanks, everybody. There's been a lot of questions, and I'm going to just throw out a few to the whole panel. But first, Naftali, just because I really couldn't resist this idea of a website with the wise guy of all the people who are betting on a trial being positive or negative. I think it's a great idea, and it actually kind of reminds me. You were too polite to say it, but one of you guys presented Naftali, you presented the ATS position statement from 2000. With a lot of very well-respected physicians and scientists, and pretty much everything that they said was subsequently proven to be not substantiated, which is perfect, and which is why we have science. And it kind of leads me to my question, which is the most popular question that people are asking, which is essentially, are we going to continue to have these old nomenclature diseases of the previous generations, things like hypersensitivity pneumonitis and sarcoidosis and UIP, or are we going to have a more molecular or patho-radiological diagnosis and scrub some of these terms? So on your wise guy's idea, is that what we're going to have? We're going to have a different nomenclature in 20 years' time, or are we going to continue to have these because they have some value?
So one is, and Katerina, I think, will appreciate it. This is my version of the big Epimenides paradox, which is, I'm going to state it now, that almost every prominent scientist that said something in confidence was wrong, right? Including this statement, probably. So hopefully people are not too confused about this. I do think we will move towards different definitions of ILDs. I think we're already seeing it. Actually, the emergence of the progressive, the sort of FILD is an example. We're starting to think about it and starting to be driven by the patient's presentation, actually, and less by what we think of the disease. And in general, I would sort of have a new classification, which would be intrinsic ILD, and then sort of driven by mutations, so driven by others, and then exposure ILD, and then autoimmune ILD, let's say. And then we could start simply getting away from the alphabet soup and going to mechanism. I think that's definitely the wave of the future. One of the most amazing things that I don't really do immunology, but we did recently peripheral blood work of HP versus IPF. And the crazy thing is that patients that look exactly the same on the CT scan look completely different on their blood, right? And I'm sort of surprised we didn't do it a few years earlier. So I do think that the future is going to be to these sort of more functional molecular and with molecular imaging approaches based on the patient and getting rid of the alphabet soup.
Yeah, thanks. And Raphaël, because you talked to us about the genetics, what's your feeling about this? Should you say that we have genetic and fibrotic, or just to pick up on Naftali's point about how we might enhance the classification. What's your piece that will be proven to be right in 20 years?
Okay, I'm not going to take too much risk saying that we're going to have additive information. I'm just saying that genetic analysis is going to give additive information to CT scan and etiology of the disease. We know for CTD-ILDs that the better the CTD, the connective tissue disease is controlled, the better the outcome is for the pulmonary fibrosis. We know that some patterns in the CT are also good marker of evolution. And we know that some genetic markers are also important. So I think we should add all of this data together. Obviously, we don't have so many therapeutic choices currently available, but I think we need to be more precise when we talk about ILD. And the better the precision is, the better we'll be able to discuss about our diagnosis. So this is my current thought. I say, let's say, for instance, I have a patient with RA, and he's got UIP pattern. And if I've got the genetic background, in addition to that, I'll give the genetic background.
Thanks. I mean, I think this is the number one question that our audience is asking, and I think it really, what you're suggesting is really helping in terms of looking at it. And I must say, I do echo Chris's idea about the screening with lung cancer, looking for ILD and being more precise in that in terms of how that may be a missed opportunity. A long time ago, I was involved in a screening program, and we picked up more ILD than we did lung cancer. So, and worse than that, we were left with how are we going to manage these patients. So I'm going to get you, Rachel, if you don't mind, to do a thought experiment because you're in the future horizons. Imagine we did a screening program on patients with lung cancer. And so the indication was people with a heavy cigarette smoking, and they were in their mid-40s. And you picked up ILD. What, our interstitial changes? What take us through the Fleischner approach as to what we might do with those patients?
Yeah, so I think definitely lots of patients out there, and I think I'm not surprised you found more early interstitial changes than you did lung cancer. So the first step is to understand sort of what the pattern is. What are you seeing? And this is where, and this is a little bit of my own bias, but where the pattern in the person, like the radiologist or pulmonologist evaluating the CT scan, matters a lot. So how fibrotic is it? Is it a pattern that looks sort of more advanced? Where are you on the spectrum? And I will say there, as everyone I'm sure who has seen these patients can attest, there are patients walking around with full-blown IPF that have been told they have asthma or heart failure or other things. So those are the easy ones in some ways. They get sort of shunted immediately into sort of a pulmonary visit. I think we need to agree on, and I would say I think there's probably a little bit more I might add to some of the Fleischner criteria about how we would work these patients up. So some sort of protocol of pulmonary function testing. They should be seen by someone, have just a physical exam, understand their respiratory symptoms. A good physical exam to look for an underlying rheumatologic or autoimmune disease, because we know those patients should be treated differently. And then probably a serologic screen for an underlying autoimmune disease if you find something you're worried about on an exam. And then there needs to be a way to follow these patients. And I think, at least in our center, we can't, our ILD clinic certainly can't handle the volume of all of these patients. And so we would need to think about a separate model for, is there an early, like our hospital has a nodule clinic, do we develop an early ILD clinic where we see these patients once a year and they get follow-up breathing tests and they're plugged into care. And we're getting, every year they're getting their lung cancer screening CT, it's being evaluated for changes in imaging as well. And then they're being able to be moved from this sort of early ILD clinic, either by the same providers who are seeing them there or different providers, into a more sort of subspecialty ILD treatment clinic as they move into that phase of their care. But I think we need to think of it, our thoracic surgery and interventional pulmonary colleagues here in the US have gotten very good at these lung nodule clinics. And I think that could be a model that we move forward with for early interstitial changes for how we follow these people over time.
That's great, and great advice, because it's going to become a very big issue. Katerina, there's a question that's come in, and it relates to COVID and interstitial lung disease. I was wondering if you could give us some thoughts. Is there an increased risk of exacerbations of IPF? Is there a worse outcome for the patients? And do we need to worry about a whole future epidemic of interstitial lung disease in some years' time?
Mm-hmm. Actually, it is a hot topic in our area. Also we know now from the studies that the IPF patients and ILD patients with severe disease at baseline, when they are infected by COVID, have a worse outcome with increased mortality. And this has been shown by different studies. So what we have to say to our patients is to enhance the awareness for vaccination, of course, and protective measures in order not to get COVID. Regarding the second part of the question, I think that when we reevaluate the patients after the acute phase and 3 to 6 months in the post-COVID outpatient clinic, and this is actually what we really developed at the ERS statement about the follow-up of long COVID patients, and now it is in press, we have to take in consideration that ILD and COVID is let's say a profibrotic condition. ILD, let's say that like that for the moment, at least when we have persistent radiological changes at CT combined with altered pulmonary physiology, we have to better close follow up the patient and decide if we are going to introduce therapy or not. And of course, to take in consideration other measurements such as rehabilitation and increased physical activity of those patients. We still don't know the results of the studies that are using antifibrotics or other agents like corticosteroids in the post-COVID phase of these patients. What we know is that some of these patients had already ILD abnormalities. They didn't have a clinically significant disease that is now revealed in their evaluation in the outpatient clinic.
I was wondering if there was a US experience, either Naftali or Rachel, have you guys any initiatives in the US, or are there any registry data that you might be able to share with us? And thanks, Katerina, for your answer. I apologize for not thanking you earlier. Maybe Naftali, if you had something, or maybe Rachel, you come in afterwards.
Yeah. So Rachel, do you want to take, or I'll take it?
You can start.
Yeah.
So there's a huge NIH initiative for long COVID. Frankly, I think it was a little bit too ambitious. So huge amount of money, multiple contracts, and that's why it's actually slow to get results. And there's several sort of smaller studies. Having looked at, we opened our post-COVID recovery clinic, I think 18 months ago, and I don't remember the numbers of patients, but it's a few hundred patients so far. Actually, ILD is relatively rare as an outcome among long COVID patients, but it does show up. And what we see sort of the, let's say, post-severe pneumonia, ARDS stuff that resolved, this is more common than long-term ILD, but still, you know, even if it's 1 to 5% of cases, when you think about the numbers of people infected, that's a huge number. Or even if you think about the people who required hospitalization. I do want to mention the other side of it, which is, I think the most common thing we see with COVID is actually unexplained dyspnea. And that's more discussion for multidisciplinary teams. The collaboration between actually Yale and Brigham and Women's showed that patients with normal CT scans, normal echoes, normal everything have abnormal exercise capacity with impaired oxygen extraction from the periphery. So there's a lot to learn, and we need these long-term collaborations. I actually collaborate with the European groups, and especially the Italian groups, to try to obtain tissues for patients from long COVID with ILD. And Anybody on the audience that wants to send me tissue, I'll be glad.
Great. Rachel, do you have any, we're going to finish up in about 1 minute. Have you any thoughts on the US experience with COVID and IPF?
Yeah, so I will say, I think similar to what Naftali said, we're in a, there's a lot of concern when patients are, develop rapid ARDS, they can get what looks like traction on their CT scans. And often as the inflammation and infiltrates resolve, a lot of that actually goes away because it's not the type of traction that we're used to seeing in IPF. So I think we've seen probably over 300 post-COVID patients in our COVID recovery center, and are working with building a consortium around Boston to follow these patients. And so true sort of progressive ILD post-COVID seems to be unlikely. It certainly has unmasked people who had ILD before that didn't know they had it. But we're seeing not as much of it as I think people were initially concerned based on the amount of respiratory failure in ARDS.
That's great. Chris, that was a fabulous session.
It was really great. What I certainly learnt is I've been really struck over the last few years how ILD's gone from a condition where many of us had a certain level of nihilism due to the lack of interventions to now a really very fertile area with treatments that are very effective and screening mechanisms to really identify patients earlier with imaging. But what I really learned today is actually that's only the beginning. And I'm sure many of you saw the same thing as I did, where there's real hope in terms of further genetic screening for genetic risk scores. There's a whole series of new potential interventions that are coming on board that may change the life course of people with this condition. And there's a real opportunity to then think about earlier screening and then earlier interventions so that we could then actually start to stop people going into established ILD rather than having to treat people with established disease. So I think that really tells me that there's a lot more to consider over the next few years, and I'm sure we'll be seeing that through future satellites and at Congress and other meetings within the ERS, so certainly look out for that. And I'd like to thank the panel for the fantastic questions and their interaction, and especially thank the speakers for really giving such fantastic talks and great insights during the questions. And I'd also like to thank you, the audience, for watching and also contributing to the online questions. So thank you, everybody, and goodbye.